This will move me towards my last talk, and that will be by Dr. Yasir Khan. He will be talking on liver transplantation in patients with ALF. He is assistant professor and consultant hepatobiliary and liver transplantation surgeon at Pakistan Kidney and Liver Institute. Sir, please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. First of all, I would like to congratulate PSH for holding such an educational activity. And being the last speaker, I think I'm a bit at the losing end, because most of this, rather many of the part of this presentation may sound a bit cliche, but the stage has been set. So, next, कैसे होता है? Right. So this is the institution I come from, Pakistan Kidney and Liver Institute. It's a national center of excellence for liver and hepatopancreaticobiliary as well as kidney diseases. That's a definition of ALF. I think everyone must be cognizant with this definition by now. This definition has gone changes over time, and the difference was just in the duration of illness. It is further subclassified based on the time duration, and I will just touch upon this classification system by Mr. O'Grady, where you can see that the hyperacute, they have a good chances of spontaneous recovery, and I want you to remember this thing because we will need this concept later on. Then yet again, this was shared by Dr. Hamid as well, but what I would like to emphasize is that viral hepatitis is the most common cause of ALF in our part of the world. And there was another paper in 2012 from Pakistan where hepatitis B and hepatitis E, they were one of the most common causes of ALF. Now ALF, it starts with a liver injury, and it is an excessive and massive liver injury causing apoptosis and with loss of a lot of cellular function of the liver, and that is coupled with activation of immune cells. So these two things, they contribute to the damage that we see in the patients in acute liver failure. And all the physician colleagues must bear me out that they would have seen patients with kidney failure, even acute heart failure. They don't have such a binary response involving all the organs of the body and leading to death of the patients. So you don't see these things in acute kidney injury or acute renal failure, or for that matter in acute ARDS as well. And this is another concept which I would like the audience to remember. We may need this again later in the presentation as well. That as you can see, the liver functional reserve, or the number of functioning hepatocytes, they decline after acute liver injury. At certain threshold, it changes into acute liver failure where there is encephalopathy along with coagulopathy. And if it falls below a certain level, then these are the patients that won't survive without transplantation. We don't know the figure, but it's assumed that probably it is 15% of the liver function. Now, one of the things which I would like to emphasize is when to refer a patient to transplant center. This is referral criteria. You can see for the paracetamol and non-paracetamol, but generally with acidosis, increasing INR, encephalopathy, shrinking liver size, and increasing bilirubin, these patients, they should be shifted to liver transplant centers. A word of caution, which has already been mentioned, but this was a great study in Liver International by Habib et al. And the bottom line is that don't transfuse them for INRs alone. They have a different mechanism. They don't bleed despite having high INRs. And the problem with the prophylactic transfusion is that it can cause volume overload, transfusion reaction, and most importantly for us, masking of INR and leading to difficulty in clinical decision making. The mode of transfer, we have discussed a lot of things, but that is how most of the patients, they are transferred. And this is a call which we got yesterday. The call was, it was just a handwritten note, not telling us much about the patient's condition, and it was brought by attendants of the patient. And one other important thing is, so there should be center-to-center communication, and these patients, they should be sent to liver transplant centers, and this referral should be, the lead should be taken by the doctors. And that's another problem of these referrals, whereby their airways are unprotected. So this is a 17 years old boy. He fulfilled the King's College criteria, and we lost him because his airway was not protected and he had aspiration pneumonia and presentation. Similarly, this child also couldn't be transplanted because of the aspiration pneumonia, as his airway was not protected and he had a grade 3 or 4 coma. Now, we all know that liver failure is a deadly disease, and I've just taken these two studies. The first one is the epidemiology of acute liver failure. This is from Germany, which is a very well-developed country, state-sponsored insurance, and yet you see 47% of the patients, they died. From our neighboring India, who have circumstances much more close to us, you can see that the mortality ranges from 60 to 80%. So as Dr. Kailash rightly pointed out, that whatever was said by Thomas Starzer in 1982, that liver transplantation remains the only definitive treatment for patients with acute liver failure. The same statement is there in 2015, that the liver transplantation is the only effective form of treatment of acute liver failure, and it still holds true today. And it is justified and supported by the fact that mortality in the pre-transplant era was 80 to 85%. And by institutions like Mayo Clinic, the survival rate was around 6%, while the survival rate has improved a lot. Yes, we do realize and recognize that non-transplant survival has improved because of improvement in ICUs and cares, but it is actually the one single treatment which has made difference, that is transplantation. And this is also supported by, at that time in 90s, when there was a 90% one-year survival in the 90s, there were, so the medical colleagues, they said that there should be a randomized controlled trial comparing liver transplantation with other forms of treatment, but that's just not possible. But transplantation has stood the test of time, and we have these many studies. For example, this was a review in which you can see data from the US and the UK that's showing the survival advantage of liver transplantation. And another evidence is that, for example, 92% of the patients who were listed for transplantation at King's College who couldn't get a transplant, 92% of them, they died. And that's an excellent paper showing the impact of transplantation, where you can see, if you look at the countries, it's covering all corners of the world. And you can see that the countries with the maximum number of transplantation, they have the minimum number of deaths, and vice versa. Similarly, Dr. Hamid was there, that he showed the data from 2017, and this is the data from 2007 and 8, but a lot didn't change. The transplant-free survival, which was 45%, is now 47%. And one other way of looking at it is that more than half of the patients, they will require some kind of intervention like transplantation. And minded, this study and data is coming from a country like US, where acetaminophen is the most common cause of acute liver failure, which has one of the good prognosis. So the principle is to select patient who will benefit from transplant and who won't survive without transplantation. And we have a lot of prognostic models to guide us about this. The other one is to avoid unnecessary transplant in those with spontaneous liver recovery, and that's a difficult one. And the most difficult is to avoid futile liver transplantation, in which it is too late. So that's the most difficult one. And the management challenge which we have is to offer a scarce organ with the lifelong risk of immunosuppression versus continuing therapy in the hope of native liver recovery. And mind it, all this is happening in the setting of acute liver failure. It usually may be middle of the night, and it's a race against time as well. So this is the original published King's College criteria. It has gone a bit of changes over years. It was the first one to differentiate between paracetamol-related causes and non-paracetamol-related causes of ALF. And I hope all the hepatologists would be cognizant with this criteria. And this has stood the test of time. We follow this at our institution as well. And this has been validated in meta-analysis as well. And it has a specificity of 82%, meaning that those who fulfill the criteria and they are not transplanted, 82% or 80 to 85% of these patients, they will die. The downside is its sensitivity of around 65 to 68%, meaning that 35% of the patients who won't fulfill the criteria may still die. So the quest for a perfect model has continued, and there are a lot of criteria. I'll just touch upon them in the next few slides. This is the French criteria, and yet again you will note in all of them the sensitivity and specificity, they are low. MELD is also being used, but if you look at MELD, it's also the same things which are mostly followed in the King's College criteria. It's the INR, creatinine, and bilirubin, and MELD performs better at higher scores, but in lower scores, the performance was not that good. And comparison with King's College, if you can look at its sensitivity and specificity, both of them, they are low. So the quest continues. Then there is another model, that's the acute liver failure early dynamic model, in which there are 4 variables and they are scored. So as the score gets high, the risk of mortality is high, and these are the patients who should be transplanted. Similarly, the clinical prognostic indicators, which uses 6 parameters, and if any 3 of them are present, that means poor prognosis. And then, as was mentioned by Dr. Hamid, the acute liver failure study group index, that's combined one special thing, and that is M30, which is a marker of apoptosis. But it had a good sensitivity of around 86%, but a specificity of 65%. And the other problem is availability of M30 in the labs in different parts of the world. Then in that quest, you can see that disease-specific models, they were tried to develop for a specific etiology, specific parameters they have been used. And prognostic models which are used in ICUs to predict mortalities, but they are non-liver specific like SOFA and Apache 2, they have also been used. Another modification of MELD, the CK18, which is a marker of hepatocyte injury. So you can see there are multiple criteria to guide us regarding selection of patients for transplantation. What are the contraindications? The contraindications, they are patients with evidence of compromised brainstem function, and as the CT was shown by Dr. Hamid, patients with confirmed invasive fungal infection or they are clinically unstable, uncontrolled ARDS or hemorrhagic pancreatitis, they are considered as relative contraindications. And there was this analysis of data of UNOS and King's College, and it identified 5 clinical parameters, which when present, they were also markers and determinants of poor prognosis. So if none was present, they had 81% survival versus 42% when 4 of them, they were present. So to guide us in that time where there is a race against time and deciding of transplantation, there's another paper from a great hepatologist, Professor O'Grady, whereby we know when to proceed and when to stop, but when to wait and in the hope of spontaneous liver recovery. And as was mentioned by Dr. Hamid, the advances is made in the medical management of these patients. So actually, as he said, there is experience tells you. So we follow King's College criteria, and at times the decision is not very easy. We have in our institution an ALF, acute liver failure care pathway, whereby we have investigations of donor and recipient, which are conducted in expedited manner. And most importantly, once the decision of transplantation is made, the workup is done, they are counseled. They are counseled. Most important is the prevention of donor coercion, because we are mostly doing the living donor liver setup transplant, as well as the family and the recipient family, they should be cognizant, and their expectations should be real. So what is considered a favorable situation for transplantation? When the patient is hemodynamically stable with little pressure requirements, cerebral perfusion pressure is more than 40, low oxygen requirement, and a good graft is available. The types of transplant which are available, they are the deceased donor, the living donor, a modification of the living donor, APOLT and ABO incompatible in both living donor and cadaveric settings. Deceased donor liver transplantation, that is considered advantageous because there is the whole organ. The disadvantage is the organ shortage. The other disadvantage is waitless mortality. And in US, the waitless mortality was 18.7% for all causes. And then since they are graded as status 1A in UNOS or super urgent in the UK, they have the highest priority and they receive the marginal grafts as well, which would be suboptimal because they may be ABO mismatched, the graft may be steatotic, the liver may be coming from a DCD donor. LDLT, the living donor liver transplantation, which we do at our center as well. The advantages are that there is a good graft quality, there is a wider window of opportunity to explore other options and explore the bridging options, as Dr. Raj pointed to. And then there is this concept of auxiliary transplantation, which I'll touch upon subsequently, but that option can be explored. The concerns are the adequacy of the graft to recipient body weight ratio, meaning that the quantity of liver which a patient receives in that time, that may not be sufficient for him. And most importantly, donor morbidity. But living donor transplant has been, for ALF, it has been out there for quite long as well. And the first one was performed in 1992 by Matsunami. And a series was published from Hong Kong in the late 90s. And the other advantage which we have, or which the living donor centers have, is a twofold drop in mortality rate in the waiting list patient was observed because there is expedited workup. So as you can see, this is survival graft, right lobe and left lobe, they are used. And if you look at the survival of patients receiving left lobe graft was slightly lower. ABO incompatible transplants, they shouldn't be used. They should only be used in dire and desperate circumstances because they are associated with inferior results. Their use in the literature has been reported in 13 to 29% of the transplant patients. And from this study from the Japanese registry, you can see it has been used in the living donor setups as well. And there are 13 patients, which meant 6.3 of their patient, 6.3% of their patients, they received an ABO incompatible graft from a living donor. So this is, as Dr. Zubairi was talking about, the histological features. So this is how it looks on the table. The liver is stiff, shrunken, and you can see these are the regenerative nodules, these. So this is a picture from one of our cases which we did 2 weeks ago. Intraoperative steps, they are a continuation of the steps which are done in the pre-op settings, and they are, the most important target is prevention of intracranial hypertension. And we have, the maneuvers utilized are head-up position, avoiding hypothermia, early hepatic artery ligation, and minimal handling. And then side by side, this is a donor surgery, a donor graft that is ready to be taken out. So it is prepared on the back bench for implantation. And then the liver is implanted in the recipient's body, starting with the hepatic venous outflow, then the portal vein, then the hepatic artery, and finally the bile duct. As I said, auxiliary partial orthotopic liver transplantation, it is pinnacle of the surgical technique, and it is built upon the physiological and pathological principles that whatever the cause of injury, when it ceases, the liver will recover. So you need to support the patient with the liver during this time. And these patients, they undergo a hemihepatectomy, half of their liver is removed, they receive a liver transplant, and once the disease is over, the injury is over, later on the immunosuppression can be withdrawn and their native liver can start functioning on its own. Unfortunately, the incidence has gone down with time. It was initially 4% in the 90s, and now it's around 1.9 to 2%. The patient selection for this, the patient should be younger with etiologies which are good etiologies, and relatively clinically stable patients who can tolerate lengthy surgeries. Not this kind of surgery. This is a picture from one of our patients who had subacute liver failure, and you can see these regenerative nodules. These are the patients who shouldn't be selected. These are the intraoperative complications. They are more prone to it. And perioperative complications, sepsis is the major killer. And one of the dreaded complications is that the patient not making a full neurological recovery. Now, what is the impact of liver transplantation? We've all been talking about that it is a definitive treatment. But the impact is, you can see, that the survival has improved. This is a look back of 3,300 patients. And over time, the survival with transplantation has improved. Yet again, the same thing, if you look at the transplants in the early era, the survival was low and now it has increased. But comparing emergency transplantation with elective transplantation, looking from this ELTR data, you can see that they have a 10% less one-year survival. And why? Because of these poor prognostic factors, which you can see, and they have been tabulated as, if you can see, they are either of male sex, increasing age, or a clinical deterioration in the pre-transplant state. These are the results of LDLT and ALF, and you can see this one study from Yamashika, Japanese registry, 209 patients, and they demonstrated a 1-year survival of 79%. And this is another study from the Asan Medical Center comparing DDLT and LDLT, and the graft and patient survival was similar. Continuing and building on the same theme, that the 1-year survival rate in the US was 78.6% for cadaveric donors, and for living donors were 87%. And one of the reason is that if you can see that the number of ABO incompatible grafts, they were more in the deceased donor setting, and the cold ischemia time was longer in the DDLT settings rather than the living donor settings. This is data compiled from many studies, and we can compare the 1-year and 5-year survival. So LDLT and DDLT, they do the same for ALF patients. There are ethical issues. I think the time is up, but I would just like to touch upon these things. Specifically, the last one, donor coercion. Because there is an expedited donor workup, and the median donor preparation time in one study was around 18 hours, and so is the turnaround time at our institution as well. Giving donor ample time to study the process and know about its ramification and results, that is something which all the caregivers and transplant surgeons and hepatologists should be cognizant of. Thank you very much.
Thank you, Dr. Yasir Khan, for an informative and to the point talk. This brings us to the end of the presentation, but not the session. Yet you have to be with us for 5 to 10 minutes further. Here we have received 2 questions for Dr. Yasir Khan PKLI. Question is asked by Dr. Mughis Athar. In your center, which score criteria you use for liver transplant? Dr. Yasir, question is for you. It is.
That's the prognostic model which we use.
So, and second question is also for you. What is the PKLI policy for receiving patients with ALF for transplantation?
Well, the policy is that we receive all the patients. And yesterday we had a talk. We had 2 calls yesterday. And one of the patient, he was treated elsewhere for like 7-8 days. So being a national center of excellence, this is a moral and sort of ethical obligation on us. So we don't say no to anybody unless there are clear-cut contraindications or there is no donor available. So yes, PKLI is open for all. All the patients who require that care, because we have a very good team. Our hepatology team is here. We have an excellent ICU team and a team of 5 surgeons. So, and the transplants can be done any time of the day and any time of the week.
So, any other question from audience? I would like to put a question to Dr. Bilal Hamid. Sir, we talked about raised ICP and role of mannitol. At what dose and what duration? For what duration you will use?
Can you hear me? Okay, yeah. So every center does it differently. As I mentioned earlier, that we treat as everyone has intracranial hypertension because we have this ICU. And so the goal is that, patients' serum osmolality, we keep it between 300 to 320. I think that's what we try to achieve. And you give a dose of a bolus like 0.5 gram or gram, and depending on that, you keep it. But when you keep them intravascularly dry, these patients are on renal replacement therapy, and with hypertonic saline, if you keep the sodium level elevated, their serum osmol goes up. So the goal is 300 to 320. Most of the time, these patients require 1 or 2 dosages. However, if you have a patient, we have seen, the one thing I should have mentioned, that as Dr. Zuberius mentioned, we don't send these patients if they have mental cell changes to get a CT scan. The only thing you wanted if you worried about intracranial bleeding. The cerebral edema and then intracranial hypertension, the examination can tell you. If they have pupillary reflexes, that's good. But if the pupils are dilated and you can see the changes, And then you can give it a bedside serum mannitol dose if you worry about it, and that is what we have. But this is a different. In the past, people have used intracranial like monitoring, and it caused more bleeding complications. We have used intrathecal monitoring, epidural monitoring, and we had a patient, I still remember as a fellow, who came in with acetaminophen liver failure. At that time, we have neurosurgery, and we were monitoring the intracranial pressure. And that patient recovered, but second day when they transferred to the floor, had a major bleed and died from that bleed. So we stopped doing, I think, so there are some non-invasive ways to keep it, but we have just in our, and in the study network, acute liver failure study group that we were part of, we had more than like 400 patients in that, and we have the lowest acute, like, cerebral edema because we were just managing very aggressively. Maybe we were doing aggressive things and maybe overcall, but if, we thought that those did help, and then when the patient started recovering, we just stopped doing like, intensive. So that's how we were managing these patients.
So further extending this question, what is your say about reducing raised ICP by creating a hypothermia and hyperventilation, and are these effective?
It's it's in the guideline, but the problem is that when we talk about minimal stimulation, right? If you keep them like, hypothermic, they start shivering, right? So the only thing is that, when renal replacement therapy that we use, that brings the temperature down. So we don't like, so that is, but you don't need to use it that much. And same with hypo, that's been recommended for any intracranial hypertension that's been studied, but we don't do it that commonly. So that's an excellent question. So we don't, but majority they are intubated in the ICU. Majority of these patients have acute kidney injury, and we start them right away, not for volume control. And then that's the one thing we always have an argument with the nephrologist, right? But they have been, especially in July when the new nephrology fellow comes in, they tells us, and like, the good thing is in a big transplant center where you have the ICU, they listen to you. So we tell them that this is what we needed. So we have been more aggressive in that regard. But it's a volume control. I don't know whether in Canada was.
Yeah, not every patient was kept in RRT, but ALF needs definitely aggressive approach, definitely.
Thank you, everyone. The talk was really good. I just have a question for you, Dr. Bilal. Can you talk about tachyphylaxis with mannitol? Because that's kind of like one of the concerns that we have is, once you start using it, frequent doses might not be as effective. Can you just speak to that a little bit?
Yeah, again, I think the tachyphylaxis, meaning they lose the effectiveness, we have seen it also. But again, with the combination of things, as I mentioned, with the CRT, hypertonic saline, we didn't need to use it that much, right? So that's the one thing. And in America, since we have access to disease donor and when these patients become candidate for transplant, we call it status 1A listing, that they become highest in there. And normally we can get an offer for transplantation within 12 hours to 24 hours, right? So then we have very quickly, they get a transplant. The sad thing is there are still number of patients in America that they're not candidate for transplantation. And believe it or not, in America, if you don't have an insurance, you will not get a transplant. And we have seen patients dying because they are in the hospital, but no one wants to pay. Hospital will not, because they were not able to afford. So they are shocked that in countries like Pakistan, we are doing free liver transplant. It does not happen in America. And you have to be like, it's amazing that, this can be done here. And that's the saddest part in that thing, that you can have a young patient who does not have the money, doesn't have it. And so that is, they are patient. The other reason patients are not candidate in US, most of these are young people, and they are, I said, if they have multiple suicidal attempt before, or they have used drugs, other drugs that maybe, although we give them one of the reason we believe that their outcomes are a little bit lower is because of lack of compliance, and they stop because these patients were perfectly normal. They were trying to kill. We had cases that patient came in and they wanted to, unfortunately they had severe depression, and then we thought that as a team that we saved someone's life. We gave them a liver. My patient woke up, got upset that, why did you save me? I wanted to die. Why did you give me a new liver? I wasn't going to take the medication. And that was correct. 6 months later, patient came and stopped taking the medication, and that liver. So I think those are the things that, that some of the reason for lower survival is that the lack of follow-up. They won't going to take the medication, and that's the one thing we have seen.
I would like to put a question to Dr. Yasir Khan. Sir, you talked about relative contraindications of liver transplant. You talked about relative contraindications of liver transplant. At what point of time you will ignore and proceed for transplantation?
So, well, as I said, it's a difficult decision in the middle of the night, maybe. So when a patient fulfills the prognostic criteria, like the King's College or any criteria which is followed in institution, they do merit a transplant. Then the next thing to look for is whether there are any contraindications for transplantation, which are not very clear all the time. So you don't have those things. So once a patient fulfills the criteria, they should be offered an organ or should be offered liver transplantation.
Yes, please.
My name is Dr. Yasir. Convincing a patient with grade 3 and 4 encephalopathy and acute liver failure to the donor that patient will make, it is very difficult. We have a patient where donor was initially ready to go for transplant, but later he denied. That patient doesn't have good survival neurologically, maybe transplant. So he slept only because his first look was the patient is in unconscious state, whether she survives after, and should I go for that liver donor surgery or not?
So if I understand your question correctly, your question is to convince somebody for liver transplantation when the patient is not in a good shape. So yes, that's, as I said, the results of transplantation, they have a lower 1 year survival, 10% lower 1 year survival, and that is because you are starting with the sicker patients. Regarding neurological recovery, that's a fear, and it happened to us once, a perfect transplant, everything was fine, every organ was functioning fine, but the patient didn't have functional neurological recovery. So there is a lot of talk about neuromonitoring protocols, and as he said, Dr. Bilal said about the use of intracranial pressure bolts. We at our institution, we do a baseline CT when we receive these patients from elsewhere, specifically to look at their chest, and now in this COVID era as well. So we do a CT brain with that as well. And then we examine them serially. Apart from that, they undergo transcranial Dopplers to look at the blood flow in the middle cerebral artery. And a surrogate marker of the intracranial pressure is their optic nerve sheath diameter. That is continuously monitored. So on the basis of all this information and in consensus decision by all our colleagues, including hepatology, neurology, and intensive care, we just try to rule out that the point where the neurological recovery is not possible, that has not been reached. But still, as far as the donor is concerned, we are very open to them with regards to the results, that the results in these patients, they are poorer and they are lower than the elective transplants. Their 1 year survival, it is supported by a large series, that's 10% lesser. But once these patients, they go through the initial 1 to 3 months period, their survival is better than those who are transplanted for chronic liver diseases, because there is no recurrence of primary disease like hepatitis B, C, or there is no recurrence of cancer. So we offer them facts, and it is their right, and that's the basics. So the last slide was about ethics. So prevention of donor coercion as well as respect for their autonomy. So that's the whole point of it.
Thanks a lot.
Now, I will move towards respected chairs for their comments. And
thank you very much. I would like to thank PSH organizer for their kind invitation. And I guess this symposium was very productive and wonderful, and a very important topic. Starting with Professor Badafaya Zuberi, he beautifully highlighted the etiology, pathophysiology, and the workup of acute liver failure. Hepatitis E in pregnancy is a very important etiology in this part of the world. And it's very critical because you are dealing with two lives. Of course, the mother gets the priority. The mode and the exact time of delivery is crucial, and it sometimes gets a very difficult decision we have to sit with the family, with the gynecologist, and so this is something very important in this part of the world. We've passing through COVID, so we have seen many COVID-related acute liver failure in past 2 years. So this is again a very important etiology to consider. The third, dengue is playing havoc in Pakistan, especially in Sindh area after the floods. And we are seeing all sorts of liver derangement and acute liver failure secondary to dengue. So again, I don't know the management differs or it's the same. Then moving on to Professor Bilal's talk, he beautifully highlighted the complications of acute liver failure. My question with Professor Bilal is, at what point in time do you consider plasma exchange in these patients? So can you answer this? And then my second question will be later.
Volume and that has been, but we are not using it currently. We have some other like liver assisted devices we have used as a, in research setting. We didn't have that much success, to be honest. So
Okay, and my second question is, are you involved in any stem cell therapy? And because the data which is coming is basically from my Indian colleagues, and they are very optimistic. They are, whenever I go to India, they always talk about stem cell, and
Yeah, yeah.
they are very fascinated by this.
yeah, always like, again, there is a lot of, I would say, excitement, but we are not there yet. We have these new, like, bioartificial livers that we are working on it, but one thing is that we haven't even find a kidney which only does one function. And we're talking about the liver, which has, so, when we had these, so we have some research studies that's been going on, but we're not there yet. There are like a lot of interest that has been, developed, but I don't think so. It's still in the research setting. And currently we are not doing any clinical trial right now. And, but there are some encouraging, some liver assisted thing and bioartificial livers that we are looking at it, but they've been working for 10, 15 years in the lab. But we will be starting a trial with them. And again, they are a group of patients. Most of them are still a bridge to transplantation, because sometimes these patients have like 4 or 5 days until they get a liver. So we are still using it. So, but not there yet. But there is, as you mentioned, there is a lot of strengths, but we're not there yet.
Okay, so the third talk was by Dr. Kailash, again a very important and illuminating talk, I must say, expressing and highlighting all the newer modalities. And I hope that we get at least a few of them in Pakistan, because just by looking at it, it seems that it will take decades to get these newer devices and newer systems in Pakistan. The fourth talk was by Dr. Yasir, the importance of liver transplantation and when to liver transplant. The problem of liver transplant in Pakistan is that there are hardly a handful of centers who are offering this. And out of those, there are very few selected centers who are offering emergency liver transplant, I must say. Most of them are offering, the elective transplant, because the team comes from the abroad and then do it. And shifting of these patients are very, very important and critical, because the ambulance person, the shifting doctor are not geared. These patients are not ordinary patients. These patients have, hypertension, so the handling, and there is enough data that coning and, the brainstem dysfunction occurs while shifting of these patients. And being in a tertiary care hospital, we get these patients, and by the time they reach, they are already, grade 4 and gap, and we have already lost the patient. So shifting is again a very important task in these patients. Now I move on to other chairperson for the valuable.
Wonderful talks by all the presenters. My first question is from Dr. Yasir, that as we know that response or prognosis in the acute liver failure, when the cause is different, the prognosis is also a different one. What's the situation in liver transplant? What is the response of the various causes to liver transplant when they are transplanted? So the prognosis is different or the same one? in acute liver failure?
Yes, that is one of the worries when you transplant an organ, that is there a continuity of that disease process which damaged the initial liver. So I think that's a very important, interesting question. But to be honest, with regards to this, there is no specific answer in the literature. Nobody has, I guess, studied these things. All the studies, they have been about the poor prognostic factors, that patients who don't do well. But with specifically vis-a-vis the causes, that when the cause was hepatitis E or autoimmune. But from what we know, that the hyperacute etiologies like the viral hepatitis or the ecstasy drugs, as was mentioned, because they cause minimal or no inflammation, as was pointed out by Dr. Zubairi. These patients, since they are offered auxiliary transplantation, and they do well. But specifically with regards to that post-transplant survival and the impact of the etiology in the early post-transplant period, that has not been studied. But the sicker the patient, with involvement of other organs like involvement of kidneys and renal failure, that makes a patient more sick. The prognosis and outcomes, they are worse in those patients.
And my second question is from Dr. Bilal Hamid. He mentioned that sedation is one of the treatment of intracranial hypertension in acute liver failure. Liver failure, and you mentioned that sedation is one of the treatment for intracranial hypertension in one of your slides, if I am right.
I didn't understand the question still.
You mentioned in one of your
propofol,
slides that sedation.
Yeah, so when you intubate someone, you need to give them sedation, right? And there are different options are there. So propofol is one of the most commonly used sedative medication, and also there are other studies have done it has anti-seizure and also decreased intracranial pressure. So if they are patient, as long as their blood pressure is fine, we use propofol. We recommend with the ICU to use propofol. It's not the treatment, but it also helps with all the other things you're doing it, because it's the many things you're doing at the same time. So that's what we were saying.
First of all, I'm thankful to the organizer for inviting me over here as a chairperson and making me to learn a lot. Secondly, it is the right time for me to congratulate the organizer again, that about 80% of the Congress, this conference is over. And in this last session, I have counted there more than 85 people. So this is a very, very important message to the organizer. This is a very successful, along with the fascinating speakers with a wonderful talk. So this was my message to this. And मेरा बयानिया थोड़ा सा मुख्तलिफ है. वो ये है कि how can we decrease the mortality when people are admitted in our hospital? This is the ground reality, that we don't have place of these people in our ICU. And even if you can be able to do it, we don't have the ICU beds properly in even the teaching hospitals. So number one, we have to advocacy for the providing these people the ICU beds, number one. Secondly, if this is not available, because liver transplant is a decades की बात है, आगे जाने की बात है, और नई जो modalities हैं, novel treatment is again a long-term planning. So we should be training our staff that they should be treating these people in the ward like ICU care. At least they must be given a quiet room as we are giving to the people as tetanus people. And then we should have a frequent monitoring as has been discussed by the people. And we should be working as a team. No hesitation, कोई शर्म नहीं होनी चाहिए उसको, उसको neurologist, nephrologist, hematologist, and the internist, all the intensive care people should be involved if we don't have the facility of the ICU. But top of it is that how can we decrease the burden in our hospital, and then we can decrease the mortality again, and that is nothing but it is the prevention. We know this is the viral infection which is causing majority of the cases. So we should be talking about prevention, this proper sewage disposal, the proper sanitation, the water supply system, number one. Number two is the proper vaccination. So B vaccination A, and we should have the place of the E vaccination as well. I do have fear if I ask that are all the people sitting over here are vaccinated properly for B, the answer will, there are many people who are not vaccinated, even this hall. What to talk about the public? So thank you very much again for inviting me over here. Thank you.
Thank you very much. I think everybody is very tired, but I've been told that I need to hold the whole audience because there is some delay, about 5
General
minutes
body
for the dinner, and that's why I have to talk. So I'm very sorry for that, but I think I can only say that with the wonderful 4 talks, everybody understands that if you have 100 people with acute liver failure, 40 to 55% will improve spontaneously. That is the key message. And 25 to 30% will require liver transplantation, and about 70% will survive if they have a chance to get the transplant. So keeping these data, and I think as Hamid says, no substitute for experience. The message is how to recognize that this is acute liver failure is number one. If we can just take this message as a physician from this hall, how to recognize an acute liver failure. And the second is time is money. You need to develop a linkage with a very experienced transplant center, because the survival of 45% is not going to happen in a general medical ward. These are figures where you have poor prognosis, up to 80% dying in a general medical ward. They only survive of these 45% when you shift them to a facility where they're managed by a team that you can trust and the patient can trust. And that trust can only come when people know that that team is experienced and they're dedicated and they will do everything to make sure that they give that patient a chance to survive that 45% figure. Now the key is how to recognize those who will need a transplant. When an acute liver failure patient reaches in the last 10 years to my ICU, we make that decision in the first hour. And that is the experience of the team to say, you said this patient needs transplant, full stop. And every team within, and then time is money. Because in the next, that patient should be transplanted within next 24 hours. And I think as Dr. Yasir said, we have transplanted them well before that. We have finished 2 transplants and we started a 3rd transplant in the middle of the night because it's an acute liver failure. You can't wait because the brain edema, the coning, the patient is gone. You give them a liver, they will not recover. They still are dead. So the timing is the key and the experience. You know, there is no substitute for that. But then the hepatology team and the intensive care, do you trust them when you shift that young patient who are young, 20 years old, with all the family running in the corridors, where there should be the hepatology and the transplant team and ICU team should exude that confidence where the relative believe that their loved ones are indeed looked after. And as you say, 40% die. So with that mortality, you need to be on the top of your counseling skills. You need to be absolutely clear of what facts you give to the relatives because they're bombarded with misinformation, advices from all over the place. So what we need in Lahore, the PKLI in the center, and with the 34 district general hospitals and teaching hospitals, where is that linkage? Where is that protocols? Where is that trust? And I think that is what we need to work on. And the responsibility of I think we know that this is the most experienced team. We know the outcomes are phenomenal, but it is the logistics of lifting that acute liver failure patient to a safe intensive care unit where the team is seen dedicated to make sure that they work very hard to make sure he survives that 40% chance or get transplanted. And I think that is, we all need partnerships, we all need dedication, and we all need protocols for that. Thank you very much.
Just one. Dr. Kailash Raj, as you know that the renal transplant system is very advanced. The patient live on renal transplant years and years. So what is the reason that hepatic dialysis could not be so advanced, could not be developed so advanced that the patient may have a reasonable time to bridge therapy for the liver transplant or other therapies?
Yes. So as I mentioned in my talk that there are various centers in the world which are performing these studies on these patients. Number one, the condition of the patient that we get is already devastated. And besides that, we don't have robust data. Upcoming years, either decade or so, will tell us about these assist devices, that what's happening and what's the future of liver transplant and where does renal replacement or liver replacement therapy stands. Truly speaking, we haven't have any data. I have never heard at any center in Pakistan, at least, which does this. No, nothing. Even PKLI does not, right? Okay. At my center, we don't do RRT even. So it's all about the future. Future will let us know that where the game is going.
Thank you.
So thank you very much. It remains for me to say thanks to respected chair and respected speakers and dear audience. Thank you very much.